Good evening to everyone and welcome to this year's last session of the APPG mock test. So we welcome our online students who are still with us, Dr. Neena, Deva, and from Tirupati, Amirpet and Guntur and Vizag. So let's make the start. Jefferson's fracture, a very easy question. I hope you can be able to shoot your answers. Jefferson's fracture, you need to shoot your answers. Very good. Dr. Fahima, you're also welcome for the online session. You need to shoot the answers so that it becomes easy for me to take the discussion forward. Yeah, at least some, because since exam is only on Sunday, the APPG state entrance, we'll at least discuss some 50 questions and say goodbye for this year's long tumultuous season of MD entrance preparation. And on Sunday, after APPG is over, on Monday we will have a discussion on the question paper of the APPG. So you're all welcome for that. We'll also have an online broadcast of that. Very good. Dr. Fahima proposes answer A, which is true. The fracture of the first cervical vertebra is basically called as the Jefferson's fracture. So what is a cock-up splint? So you need to give some quick answers. Typically, what is a cock-up splint, doctor? It is very good. It is the radial nerve palsy for which we use the cock-up splint. Now, if you look at the pulmonary embolization from the deep vein thrombosis as a complication of the long bone fracture, usually after the injury, how much time later will this complication basically will occur? So, we need to remember that it is 4 to 5 days after the injury, there is a development of pulmonary embolization as a complication. Now, Seddon's classification is one important favorite question of the examiner. What is neurotmesis? Typically, the axons as well as the nerve, they become broken and there will be a proximal and distal degeneration, which is basically called as neurotmesis is a true statement. You also keep punching your answers. So, we will be going a little fast in our discussion. We encourage you to keep shooting your answers. Suddenly, if we discover that your answer had gone wrong, we can go back to that question and check why you have gone wrong. That's the reason, keep punching your answers. So, doctor, the next question. Shoulder dislocation by the Kocher's maneuver. What is the order in which we do the correction is one of the important questions of the examiner. So these are all the simple questions. Even tomorrow's APPG paper also is more or less on a similar line. So we do traction, external rotation, adduction and internal rotation is the order in which. Very good. Dr. Raj is also the participating member. So we wish to hear some good news of having had done a very salubrious performance in the tomorrow's exam. So the order in which the Kocher's maneuver is basically performed is traction, external rotation, adduction and internal rotation is what we have to basically remember. Now Galeazzi and Monteggia fracture is one of the common questions of the examiner. So what is your answer about question number 6? That's good. Raj also feels the same answer. Galeazzi is the fracture of the lower third of the radius with the dislocation of the radio-ulnar joint is what need to be remembered. Either Monteggia or Galeazzi. One of these two fractures is a frequent question in by the examiner. Now, what is the most common component which is involved in the sprained ankle? Whenever we say ankle spraining, which ligament is the one which is most commonly involved is the question. So Dr. Fahima has to shoot one brilliant answer. Very good. Raj proposes option B, which is in fact correct. Anterior talofibular component of the lateral collateral ligament is the one which is the most common component which is involved in the ankle spraining is what need to be remembered. Now you have a patient who has acute osteomyelitis. So what is your answer? What is one of the earliest radiological sign to appear on the X-ray in case of acute osteomyelitis? Very good. Dr. Raj proposes periosteal new bone deposition. So which is one of the very, very early features is what we need to remember. So this is how on the head of the second metatarsal with a periosteal new bone formation, this is a classical feature which is found in the case of osteomyelitis. Now what is the most common site for the development of infection of the hand? So we need to know that it is acute paronychia. Acute paronychia. Very good. Dr. Neena from Pune also is now actively involved in the discussion. Very happy to know that. So today actually our medicine class is scheduled as usual, but because of this farewell party, it is called as for the seniors who are going to the exam. So we are giving a farewell to them for the forthcoming APPG state entrance. So that's the reason today we could not have medicine class, but from tomorrow as planned in the schedule, we will continue to have the medicine session evening 5 to 8 religiously without any interruption. So acute paronychia, very good. So it is a suppurative pus forming inflammation of the nail fold and the soft tissues which is typically called as the paronychia. Now you are manipulating a club foot. What is the order in which you will be manipulating? Straight the same question will come in the tomorrow's exam. There is no wonder about it because it's one of the very, very routinely asked question in the exam. So what is your answer? Who is going to give you the correct answer? Remember, all India entrance, A for adduction, I for inversion and E for plantar flexion actually. So this is the typical order in which at the time of the Ponizetti's technique, we will be, it is adduction inversion, plantar flexion is the combination, unlike what Nina has thought it as option A, which is not true, it is option D. Astasia abasia is a gait disorder. In which condition do you see this? Astasia abasia is a very, very classical gait disorder which you need to remember. In which condition, doctor? Parkinsonism, you all know, there is a shuffling gait. Peripheral neuropathy, they feel that they are walking on the cotton with wash basin phenomena and episodes of falling down whenever they are closing their eyes. In cerebellum, you know, wide, unless they keep their legs wide and walk, they can't be able to hold a balance. So question number 11, Raj guessed it as option A. Good guess, so wrong answer. So no problem. So hysteria, patients with conversion disorder will have astasia abasia. Astasia refers to the inability to maintain a station. Abasia refers to the lack of the motor coordination while walking is what you have to fundamentally remember. That's good. Fahima correctly answers it as the conversion disorder, hysteria. Now, water sclerosis, this is a very, very easy question, world's easiest question. So it's called Gerhard's notch. Gerhard's notch, that's good. So, but the challenge here is it the air conduction curve or bone conduction curve? Where do you find the dip of 2000 Hertz? Who will give me the correct answer? So you need to keep punching answers very fast. That's how we will be able to conclude the session. That's good. Yes. Question number 12. Very good. So I am happy to know that You are still thinking bone or air, bone or air, bone or air. So I give you the answer as dip of 2000 hertz. Raj has correctly answered at last. Dip at 2000 hertz of the bone conduction curve, Gerard's notch. Hypopharynx. What constitutes a hypopharynx? That's good. So it is the piriform fossa, posterior pharyngeal wall, post-cricoid area. All of this is basically called as the hypopharynx. There is a carcinoma in situ in the larynx. What do you want to do with that? So remember, doctor, tomorrow's Sunday exam of APPG, laryngeal cancer and nasopharyngeal cancer, invariably there will be a question. You have to be very sure you will remember me while answering in the exam hall. Deva was clean bowled. He proposes radiotherapy, but it is a carcinoma in situ, which you should not forget, in the vocal cords. Fahima and Raj also are biased about radiotherapy, but the correct answer will be stripping is what you have to basically remember. When it is in the carcinoma in situ stage, it is the surgical stripping or endoscopic laser surgery which are considered to be the important part in the management of carcinoma in situ. Now with regard to the Meniere's disease, oh, no problem. Raj feels about it in an occasion where he need to feel wow. So, but doesn't matter. Especially topics like laryngeal and nasopharyngeal cancer or vocal cord palsy, adductor, abductor, they are all the favorite topics for the APPG exam. So you should not do a mistake, but no problem. Still you can quickly pass point yourself and then review these 3-4 important ENT topics as I mentioned. So Nina comes up with the answer Parakisis wilsii, which is a otostenosis feature, not Meniere's. Very good. Even Raj also proposes the same. So we have a Tullio's phenomena in Meniere. What is that? Sound induced vertigo. Then you have Lermoyes syndrome, which is a variant of the Meniere's, which is characterized by attacks of tinnitus and diminished hearing, followed by vertigo, after which hearing once more will improve. It is a variant of Meniere's. Then otolithic crisis of Tumarkin means what? In this, the patient will have a sudden drop to the ground in case of the otolithic crisis of Tumarkin without any other symptoms of Meniere's. So Meniere's is associated with Lermoyes, Tullio, and Tumarkin's crisis is what need to be remembered. Now, inner ear malformation can develop with thalidomide, cytomegalovirus, German measles, all of them are associated. Now, in acoustic neuroma, this is another challenging question. If this question comes in the tomorrow's APPG, you should not think twice and you should answer straight. Let me check how you will respond to this question. Shoot your answers, doctor. In acoustic neuroma, question number 17, very good. Raj, 100% correct. Fifth cranial nerve is what you need to remember. I think Raj is fully ready to blast the tomorrow's paper. So, CSF rhinorrhea, it is typically diagnosed by which important entity? So, who will give the correct answer? Dr. Nina also correctly proposes that CSF rhinorrhea. Is there any way by which you can be able to differentiate a mucus discharge which is caused by the common cold versus that of the CSF which is getting leaked out of the nose? Very good. The correct answer as mentioned by Dr. Nina from Pune is beta-2 transferrin, which is the correct answer. That's good. Now, a 55-year-old conductive hearing loss with the facial pain in the temporoparietal area and the lower jaw with the immobile soft palate on the right side. What is this entity basically called as? That's good. Raj has correctly answered that it is Trotters syndrome. Very good. Trotters is a clinical triad which you need to remember is a combination of unilateral deafness, neuralgia affecting the branches of the trigeminal along with the defective mobility of the soft palate, which is the combination which is called as the Trotters syndrome, is what need to be remembered. Now doctor, this one favorite question of the examiner asked in even tomorrow's exam, Sunday exam also, this can come as a question. Tensor of the vocal cords. Which muscle is called the tensor of the vocal cords? Who will give the correct answer? Question number 20. Yes. Between all these muscles, which is the only muscle which is the tensor of the vocal cord. Excellent. So Raj is fully ready to blast the heat of APPG on the Sunday. I am very confident, I am very sure about it, because these are all standard questions, standard answers. You must give the answers without any bickering here and there. That should be confidence. So cricothyroid is the muscle which is the one which is called the tensor, is what need to be remembered. Now if you take direct laryngoscopy, all the other conditions are the contraindications for the direct laryngoscopy. Which condition is not a contraindication for the direct laryngoscopy out of all these 4 options given? Who will give the correct answer, doctor? Question number 21. That's good. Most of you have correctly thought it. Diabetes is not a contraindication, but dysphagia, trismus, cardiac decompensation, so they all become the important contraindications and indications of laryngoscopy you must be very, very sure about. Now this is a very easy question. Which iris abnormality do you see, doctor, in neurofibromatosis between Bussaca nodules, Lischke nodules, Brushfields spots and iris perils? Who will give me the correct answer? That's good. Our online student Shreya is also now confidently participating in the discussion. That's good. Lischke is the one which need to be thought for. It is the pigmented hematomatous nevus which is found in the iris in the case of the on the slit lamp examination in the case of the neurofibromatosis. Coepes in Bussaca's nodules. Typically in the case of the granulomatous inflammation we find them. Hansen's disease can lead to plasmoid iridocyclosis, and there can be corneal neovascularization with iris pearls which can occur in Hansen's. Brushfield spots are the ones which need to be remembered in the periphery of the iris, and they can be seen in the case of the Down syndrome. Now doctor, with regard to sarcoidosis, what is one of the important feature which you need to remember in relation to sarcoidosis? Who will give me the correct answer? One confident answer please. That's good. So question number 23. Do you think choroid plaques or angioid streaks or band keratopathy? Which one did you listen? That's good. Raj correctly answers it as band keratopathy is the one which you classically come across in the case of the patients who are having the sarcoidosis, is what need to be remembered. Then typically, where do you see black cataract? Typically a cataract which got hardened and which has become dark brown is the one which is called as the black cataract. Now coming to the trachoma, what is except about trachoma? Which feature you don't see in trachoma is an important question. Question number 24. Who will give me one solid answer? That's good. Raj proposes tylosis. No sir. Tylosis, trichiasis, entropion, they are all the features which are seen. Even Deva also was clean bold thinking of tylosis. No, no, no. It is the ectropion which is not seen. What you see is basically inrolling, inward rolling, which is called as entropion, is what you typically come across in case of trachoma is what need to be remembered. Now, typically this is a patient, you can see in the fourth stage of the trachoma, there can be a shrinkage of the cornea and conjunctiva along with the scarring and leading to the development of the entropion and trichiasis is what you have to ultimately remember. Now, there is a young patient, recurrent vitreous hemorrhages are there. Classical story. It is a vasculitis involving retinal vasculature. So, who will give me what is this condition basically called as? That's good. Raj is very confident. Ceales disease is what need to be remembered, which is a idiopathic obliterative vasculopathy involving the peripheral retina in the case of the young adults is what you have to remember. So, there is a typical fluorescent angiogram with the leakage from the peripheral retinal neovascularization in the case of the Ceales disease. Now, all these muscles are coming from the orbital apex. What is except about it? Which muscle is not from the orbital apex? Question number 26. Who will give me the confident answer, doctor? Quick answer. That's good. Very good. So, typically, it is Raj proposes C, superior oblique. He narrowly missed it. Inferior oblique, except inferior oblique. Inferior rectus, superior rectus, they are all the ones which typically originate from the orbital apex. Shreya also thought similarly about superior oblique, but that is not true. So, 63-year-old bronchial asthma patient, which is the topical medication which can lead to the worsening of the bronchial asthma, which we use in the management of glaucoma, etc., etc. Question number 27. That's good. I think it's an easy question. Timolol. Timolol is a beta blocker, which is not, which can worsen the bronchial asthma. Now, a 25-year-old girl is using spectacles for the last 15 years, now comes with photopsia. And to clinch the diagnosis for the problem of sudden onset of a photopsia with loss of vision, what is the best way that you can be able to diagnose? First of all, you must know what is the diagnosis we are suspecting. Then you can be able to answer it correctly. Very good. Raj has correctly said retinal detachment. And retinal detachment is identified by indirect ophthalmoscopy is what need to be remembered. Excellent, excellent, doctor. Now, the most common cause of the blindness in India, without any hypocritical answer, simple, Mera Bharat Mahan question, this is, you need to answer it correctly. Question number 29, who will give me the correct answer, doctor? Right or wrong, doesn't matter. Cataract, absolutely right. Cataract is the most common cause. Don't be biased by vitamin A deficiency or anything else. Now, retinitis pigmentosa, what you get is called as tunnel vision. Tunnel vision, why does it tunnel vision occur? After entire periphery got destroyed like Adolf Hitler's empire, ultimately there is what is left is only a tunnel at the level of the central vision. Central vision is guided by macula. So, that is the reason. What is your answer, doctor? That's good. Nina for our earlier question said cataract. Very good. I am happy. And Raj already has shot his answer as macula is not in early stage. Macula is in the late stage in retinitis pigmentosa. That's the reason what you get is basically called tunnel vision is what need to be remembered. Now, there is a congenital glaucoma. Do you think both the eyes are affected? Are the medications effective? Or do you want to do surgery? Or is there any association with neurofibromatosis and Sturge-Weber with this? What is accept about it with regard to the congenital glaucoma? Excellent. Raj and Deva have correctly answered. It is not medication. Fundamentally, there is a blockade for the CSF, the aqueous humor drainage. Hence, you need to do surgery in case of congenital glaucoma, goniotomy has to be done. Now systemic inflammatory response syndrome, what is that key feature which is not a manifestation of systemic inflammatory response syndrome? Who will give the correct answer, doctor? Question number 32, one confident answer, that's good. So, which is not a manifestation of systemic inflammatory response syndrome. Raj has correctly said, there is no bradycardia. It is the tachycardia is the one which need to be basically remembered. Now, this is a very fundamental question, doctor. If we do this question wrong, we need to regret that our internship posting of that valuable 3 months in surgery is a wastage. So, of course, in surgery you might have handled a lot of suturing without knowing the differences between what are the absorbable and non-absorbable suture. Sometimes working is different from knowledge. You may have knowledge, you may not work. You may work without knowledge. Either of the two. Question number 33. Raj proposes polydioxanone as one of the answers. Excellent. That is in fact the true answer. So this list you try to remember, doctor, that we have surgical gut, chromic gut, plain gut, Dexon, Vicryl, Maxon, they are all absorbable. Then we have silk, ethylone, dermalone, proline, ethibond, they are all basically non-absorbable sutures. That's what you need to remember. Intraoperatively we give radiotherapy in some conditions. Which is the condition where we give intraoperative radiotherapy? Question number 34. Who will give me the correct answer, doctor? Intraoperative radiotherapy at the time of surgery. One of the standard questions. That's good. Pancreatic cancer, as most of you have correctly thought. Even Deva also proposes the same. But Fahima went a little, Fahima thought it as 34D, gastric cancer. No sir, pancreatic cancer, very standard question this is. Now Hogarth's Pringle's maneuver. Some of you are going to become surgical gastroenterologists down the line, and you will be super specializing in hepatology. You need to correctly answer what is meant by Pringle's maneuver. In hepatobiliary surgery, you apply pressure to what? Question number 35. Give me one confident answer, doctor. Question number 35. Fahima proposes portal vein, or is it hepatic artery? Oh, no, doctor. They also went wrong. Portal vein is not the answer. Pringle's maneuver, we apply a large hemostat, which is used as a clamp to clamp the lesser momentum, interrupting the blood flow through the hepatic artery and the portal vein, is what you have to basically remember. Now the air in the biliary tract, what does it basically indicate? It indicates everything except, if you do endoscopic procedure and do papillotomy, will you be leaving some air into the biliary tract? Possible. Fahima answers it as gallstone ileus. Gallstone ileus also can let the air to make an entry into the gallstone ileus is a fistulous tract between the biliary system and the intestine. So there is a reason air can very much enter into biliary tree. Any other answer? Fahima revises her answer by saying sclerosing cholangitis. Excellent. That is the correct answer. So this is a typical right upper quadrant ultrasound where you are able to see transverse view which is showing the ecogenic structures within the liver consistent with the biliary tract air is what you are able to basically see in this. This is the CT of the upper abdomen which confirms the presence of the biliary tract air basically. Now which testicular tumor is very common in the cricoid testis, doctor? Very simple question. Undoubtedly, as rightly mentioned by most of you, yes, it is seminoma, very radiosensitive, and it is the tumor which you find in the case of the cryptorchid testis is what need to be remembered. Red proto-oncogene and medullary carcinoma of thyroid, another very easy question. Anderson-Hines operation, very classical question. Whenever there is a hydronephrosis, typically we will be doing when there is a uretero-pelvic junction fibrosis, then leading to hydronephrosis, then we will try to bypass that narrowing stenotic area at the uretero-pelvic junction by doing the Anderson's-Hines. Now, this is a typical IV pyelogram which is showing the uretero-pelvic junction obstruction with the dilatation of the collecting system. And typically, Anderson's-Hines is considered to be the procedure of choice for the management of this. Now, a 45-year-old man, I am happy our online student number has increased to 17 viewers. And since next week is the exam, lot of people love to spend silent moments in the reading room. But at least 17 of you have the courage to be part of the today evening, no problem. But on Monday, on 18th, 17th is the APPG, 18th we will morning 10 o'clock, like the budget session, we will have a discussion on the key, because it is said that question paper is going to come out, they are going to give it out in the exam hall. After coming out of exam hall, we can take an opportunity to have a discussion. So please tell your classmates to attend the discussion and also contribute your active participation. We will run it in an open channel without the need of membership. So question number 40, very good. So answer B is proposed. Biopsy is the Supreme Court judgment, doctor. FNAC is a order passed by the Sessions Court or a District Court. There is always an appeal possible. So that's the reason if you want a Supreme Court judgment about diagnosis, always it is the lymph node biopsy superior than that of the FNAC. Now a 30-year-old right iliac fossa mass, and on laparotomy there is a carcinoid 2.5 centimeters is being found. What is the next line of management? So based on the size, we basically decide the line of management. So question number 41, please respond, what is your answer? Deva proposes segmental resection. Of course, option A and B are the same options. The treatment of choice is surgical excision whenever it is feasible, and based on the size and the location, and if it is localized tumor, if you do surgical resection, there is a 90% survival rate. Now with regard to the thyroid cancer, what is false except means true statement, which is the only true statement out of all these 4 statements given over here. Question number 42, who will give me the correct answer? Yes, who will give me the correct answer, doctor? With regard to the thyroid cancer, what is your answer? Option Raj proposes answer B, so also Deva proposes B. Hurthle cell neoplasms are the variants of follicular cancer, not medullary. How can you do such a simple mistake, doctor? No. Question number 42. Raj proposes microcarcinoma is less than 1, not 1, but it is 1.5. 1.5 centimeter. Oh, Raj narrowly missed. FNAC, can it differentiate? It cannot differentiate, right? Right. So C is a wrong statement and B is a wrong statement. A that way, it should be ideally 1. Okay, what was asked? Micro, no? Right. Occult carcinoma means 1.5, micro means 1. Very good. I am happy. Raj is correct. That's right. Even Deva also is correct. Now, Rigler sign, it's also called double wall sign. It's a classical feature in case of pneumoperitoneum, where on X-ray there is a air present on the inside and outside, luminal and peritoneal side, both the sides of the wall, giving the Wriggler sign positivity. Now you can see the typical Wriggler sign, air on both sides and falciform ligament. So these are the two important things, indicators. Now FAST is a technique, focused abdominal sonography for trauma. Question number 44. Who will give me the correct answer? Is it good for even hollow viscous or for only the injuries of certain viscera? Is it more sensitive or is it equally sensitive for everything? What is your answer? Question number 44. Hollow viscous injury is not easy to diagnose if you do the FAST technique of ultrasound. That's right. Deva also correctly answered. FAST is accurate if more than 100 ml of blood is there. The main purpose is to detect the pressure of the free intra-abdominal pericardial fluid. If it is a penetrating trauma, unlike a blunt trauma, it is unreliable to exclude the injury. So these are all the precautionary caveats that you need to remember in relation to FAST technique. FAST is another favorite topic of the APPG examiner, which you need to be very sure about, doctor. Now, what is the most common cause of subarachnoid hemorrhage? This is a very easy question, that it is the berry aneurysms which will undergo the rupture. If you want to identify fistula in ano, what is the gold standard investigation you like to call? Gold standard. Gold means confirmatory in nature. It is the MRI which is called the gold standard investigation, is what you need to basically remember. Now, which patients will pass their skeletons into their urine? That means there is a severe calciuria. So which condition may there is a severe loss of calcium into the urine, doctor? Passing the skeletons into the urine. Question number 47. Very good. So Fahima correctly proposes hyperparathyroidism is the condition which need to be remembered. It causes recurrent multiple stones because of the hypercalciuria and hypercalcemia and the resorption of the bone and release of calcium into the blood. So that's the reason it is called passing the skeleton into the urine. Vinod and Raj and Fahima, all of them have correctly answered it. For the extradural hemorrhage, what is the most common source? You know very well, it is the arterial bleeding. That's the reason middle meningeal artery is underlying one. Verres needle, let me check. Please shower your responses for this question, doctor. Let me check how many of you will correctly answer. Verres needle, where did you listen about this name? Question number 49, excellent. Fahima has picked up that it is an illustration of the laparoscopy and correctly answered. That's good. It's a laparoscopic needle basically. Now this question, Parkland formula and the Burns fluid requirement calculation, doctor. You will remember me on the 17th Sunday exam. Ditto to ditto, a similar question will come on the Parkland formula, because that is a favorite topic of the examiner. Many times if you see the old papers, on the YouTube, we have hosted all the previous APPG discussions. You can freely watch. Already we have nearly about 370 subscribers with about 45,000 views. You can also inform your friends to also subscribe. Our channel is youtube.com/onlinembbs. So there you have about 380, 390 videos hosted, and we keep on hosting new and new videos. So knowledge is free for a good amount of time. So very good. I am happy to know Raj and Deva have correctly calculated. So what is the formula? 4 ml per kg body weight per percentage burn. So he is a 40% burns 50 kgs. So there is a reason what should be calculation 4 into 50 into 40 which is 8000 ml. But all 8000 you don't give. You give 4000 ml in the first 8 hours of the post burn is how you will be replenishing the fluid in case of the Parkland's formula is what need to be remembered. Now a patient of sweating and erythema in a place of the previous parotid surgery. I think a very, very easy question. So how do you want to manage a case of Frey syndrome? Frey syndrome due to the aberrant innervation of the auriculotemporal nerve. What is the clinical management of it? 51, very good. Fahima comes with C, but there is no role for heart fermentation. What we can do is for the Frey syndrome, we can do all the other maneuvers which have been mentioned. Injury, injecting the botulinum toxin, surgical transection of that aberrant innervation, and application of the anticholinergic drug like scopolamine as an ointment. There are all the various options which are available. Hashimoto's thyroiditis, very, very classical question. Please shoot me your respective answers, doctor. Question number 52. Let me check who will give the correct answer. 52. Hashimoto's thyroiditis typically will lead to the development of which histological variety of thyroid cancer? 52. Excellent. Fahima thought follicular. Raj, exam going, thought it as papillary. Anybody else? Deva also second scheme, which is correct. So papillary is the typical type of carcinoma. Carbuncle is the infective gangrene which is mainly due to Staphylococcus aureus. Basal cell carcinoma is locally malignant, it doesn't spread. And in thyroidectomy, this is an interesting question. You need to throw your answers to me. Question number 55. Who will give me the correct answer? In thyroidectomy, you are the surgeon in charge. You want to prevent the injury to the external laryngeal nerve. What do you want to do in order to prevent it? Very good. Now we are getting answers from our new classmates. Jubair is participating. One of my first batch student in 2000 was Dr. Jubair from Deccan Medical College. Probably by now he might have become a professor somewhere. So Jubair reminds me our first student. That's good. So B, he proposes B, upper pedicle. Some of you are proposing A. A is the correct answer. It is the upper pedicle should be ligated close to the thyroid, not far to the thyroid. That's what need to be remembered. So this is how the external branch of the superior laryngeal nerve medially identified to the superior thyroid pedicle, and we ligate the superior pedicle as close as possible to the superior pole of the gland is what you need to ultimately remember. Now this is a very, very easy question. Saint's triad includes diverticulosis, hiatus hernia, gallstones. All of you know very well. Then tracheoesophageal fistula, it is a blind proximal and the distal end communicating with the trachea is the type which is the most common type. In child's classification, you know, it is the albumin, bilirubin, prolongation of PT, banana, you need to remember, B for bilirubin, A for albumin, N for neurological status, that is encephalopathy, and another A is for ascites and PT. They are the important part of the criteria. Now, most of the gallstones, they are radiolucent. Most of the renal stones are radio-opaque, except few exceptions like, you know, what are the radiolucent renal stones. So this is a sickle cell anemia patient with bilirubin gallstone, but bilirubin gallstones are opaque. But most of the gallstones, cholesterol containing gallstones, they are all radiolucent is what you need to remember. Now in the modified neck dissection, who will give me the correct answer for this? Question number 52, question number 60. Give even confident answer, doctor. What is preserved Which structure is preserved? Excellent. Fahima and Raj in unison propose, except is omohyoid. That's right. We retain sternomastoid, internal jugular vein, spinal accessory. They are all the structures which are preserved. So, which are preserved, which are sacrificed, you need to have clear-cut remembrance of that list, doctor. One of the favorite questions of the examiner. Oh, this is a very, very easy question in the planet. It is the gastroduodenal artery, which is the one which will bleed in the case of a perforating duodenal ulcer. In ankylosing spondylitis, we see upper lobe pulmonary fibrosis, amyloidosis and prostatitis, not retinopathy. So, what we see is in ankylosing spondylitis, uveitis is what we see, not retinopathy. So, this is a typical upper lobe pulmonary fibrosis, which you see in the case of the ankylosing spondylitis. Now, coming to the pheochromocytoma. What is pheochromocytoma associated with, doctor? It is associated with hyperparathyroidism, neurofibromatosis or medullary carcinoma of thyroid in multiple endocrine neoplasia. So, they are all the various associations of the pheo. So, MEN 2A, 2B, neurofibromatosis type 1 and von Hippel-Lindau, they are all associated with pheo. Then in Edison's, what do you see, doctor? There is no mineralocorticoid activity. Normally mineralocorticoids retain sodium and lose potassium. So, if there is no mineralocorticoid activity, what you find is hyperkalemia, not hypokalemia. So, what is orlistat? It is a lipase inhibitor which is used in the management of diabetes and obesity, etc., etc. Now, Atkins diet means what? Typically, it is a carbohydrate restricted low caloric diet administered for the people to lose their weight, is basically called Atkins diet. So, where do you see anti-mitochondrial antibody positivity? Primary biliary cirrhosis. You find a middle-aged woman with significant amount of pruritus along with anti-mitochondrial antibody positivity defines the primary biliary cirrhosis. So, you know very well, anti-Rho is for the neonatal lupus, anti-ribosomal for CNS lupus, anti-LKM, this is going to come in the Sunday's exam. So, be very sure, anti-liver kidney, M is for muscle or mitochondria, you need to check that. Autoimmune hepatitis, anti-RNP, you should not forget, mixed connective tissue disorder. So, what are the various causes of the macrovesicular fatty liver, doctor? So, you must know the differences. Typically, it is the alcohol, obesity, diabetes which are all associated with the macrovesicular steatosis. And this is a typical example: alcohol, diabetes, obesity, steroids, minocycline, amiodarone, iron. They are all macrovesicular. Whereas the causes of microvesicular, you should not forget the list of the causes, because sometimes this can become an important issue for the examiner. Which are macro, which are micro, which are both macro and also micro, you must be 100% sure. So, Reiss syndrome, valproate, ketoprofen, and in the case of all these scenarios, you have microvesicular steatosis. Should be your answer, doctor. Let me check how many of you are good in channelopathies is one important topic. That's good. One of you have gone and subscribed to the YouTube video. That's the reason number of subscribers increased to 370. That's good. So, now the modern learning has become easy. We can raise online polls. We can give you online tests for solving and coming for a discussion. We can be able to create discussion forums and raise a topic and make it debate academically. So, learning is no more sitting in a live class with hundreds of our classmates and listening and yawning in the classroom. Now, you can actively participate. So, our very philosophy of running onlinembbs.com is to make use of all the modern technology, different forms of e-learning and mobile learning, and then inculcate and ignite that enthusiasm for preparation. That is the whole idea. So question number 69, Mridula has joined the game. She proposes episodic ataxia. Raj also is on the same point, which is correct. So the other day, evening 5 to 8 session, when we were discussing cardiology, we discussed Brugada. Idiopathic ventricular tachycardic episodes will be there in them. So Brugada is an example of channelopathy. So cystic fibrosis chloride channel. Episodic ataxia is voltage gated potassium channel. Erythromelalgia is one more sodium channel. And hyperkalemic periodic paralysis. Tomorrow Sunday APPG you are going to have this question. You can trust me. Hyperkalemic is voltage gated sodium channel and hypokalemic is voltage dependent calcium channel. So calciumopathy is what you find in hypokalemic. So which one is what is one of the important questions which you need to remember. So I leave all this literature for you to review, doctor. Now, in which tumor do you see paraneoplastic cerebellar degeneration? How do you know cerebellum got degenerated? If you take an MRI, very simple. These are called folia. Folia are generally not very prominent. If there is a prominence of folia means there is a degeneration in the matter of cerebellum. Even on X-ray, prominence of the folia is a way to identify cerebellar degeneration. Question number 70. Very good. Fahima proposes, oh no, small cell carcinoma is the classical tumor where cerebellar degeneration is discovered, doctor. Question number 70. Ovarian, breast cancer, Hodgkin's, all of them are associated with a paraneoplastic cerebellar degeneration. So you can see a prominent folia structure in the MRI, which is an important indicator of cerebellar degeneration is what need to be remembered. Now, what is the most common cause of death in chronic kidney disease? This is an interesting question. Who will give me the correct answer? Question number 71. Throw me your responses, doctor. That's right. Question number 71. Who will give me the correct answer? What is the most common cause of death in case of chronic kidney disease? I know you will give me varied answers, but I will give the correct answer. Vinod said D. Fahima said C. Raj is biased about D. Most common is the ugliest, dirtiest way of asking questions. Because there, if you use guesswork, you are out of the game. I am saying all of you are wrong. Try between A and B. One more opportunity given for you. Lifeline. Who will give me the correct answer? Not infection, not metabolic disturbance. Now give me. Now every one of you will correctly answer. Tara also is into the game. Fahima, Raj, Tara, everyone is now picking up ischemic heart disease. See, doctor, if you are a nephrologist, you are very close to be like a general medicine. After general medicine, we do DM, no? Doctorate in medicine. If you do DM cardiology, chance of forgetting medicine is more. Neurology, chance is more. But if you are in nephrology, you are as good as being in general medicine. Because infections and ischemic heart disease, atherosclerosis, all this multitude of problems are common between diabetes, between general medicine and nephrology. So some of you are going to be nephrologists, right? So ischemic heart disease. Chronic kidney disease by itself will promote a bad lipid profile leading to furtherance of ischemic heart disease. That's what you need to know. So if there is a symptomatic patient of multiple myeloma, no bone pain, what do you want to do? Excellent question. Question number 72. Once more I am going to see varied responses from all of you. Give me one confident answer, doctor, for this. If there is an asymptomatic patient of multiple myeloma, what is the treatment that you want to offer? Question number 72. Raj proposes regular follow-up. Ask him to regularly take a renewal OP card and ask him to come back. Jubair also proposes the same, which is correct. So, they have done a lot of studies and had decided when to treat, when to not treat. So, who are considered to be low risk, high risk, and accordingly based on M protein level, Benz-Jones proteinuria level, whether lytic lesions are there or not, they have stratified the patient into various risk groups. Now, doctor, which anti-tuberculous drug can cause interstitial nephritis and thrombocytopenia? Take it as my word. There can be one anti-tubercular drug, one HIV drug, last 3 days, Daskatis. Most important things you need to read, sleep, love to remember and go to exam. There is no way. 73. Raj says yay. Isoniazid. Fahima proposes streptomycin. Anything else, doctor? Much more simple answer, doctor. So, how can Raj can forget rifampicin? What is rifampicin called as, doctor? Rifampicin is called Raja among anti-tubercular drug. Very powerful drug. Unless it is very bad problem, don't remove rifampicin in ATT. So Raj can't do this mistake. That's right. Rifampicin is called Raja. But Raja can lead to interstitial nephritis. It can lead to thrombocytopenia is what you have to basically remember. So hepatitis, rash, interstitial nephritis, thrombocytopenia, hemolytic anemia, they are all the problems which can occur with rifampicin. So you can't do this mistake. No problem. Kusumal sign, I should not use the word not seen, but less likely to be seen. In which condition? Who will give me the correct answer? That's right. In cardiac tamponade compared to constrictive pericarditis is more likely to lead to Kusumal sign than that of the cardiac tamponade is what need to be basically remembered. That's good. Now, which is not associated with low complement levels, Very interesting question. This is going to come in the tomorrow's exam. One question on glomerulonephritis, doctor. You will remember me in exam hall on Sunday. Glomerulonephritis, without that there is no paper. 75. Very good. Fahima says PSGN. Raj reasonably guesses it as HUS, which is the correct answer. So complement levels are typically decreased in lupus, PSGN, MPGN, cryoglobulinemia, but in TTP HUS levels are normal. Very standard question which you can't do mistake in the tomorrow's exam. Now doctor, in this little time available, try to revise. AML, ALL, CML, CLL, hairy cell leukemia, myelofibrosis, polycythemia. These 7 or 8 conditions, you will take not more than half an hour. But if you revise these 8 conditions, 1 or 2 out of this 8 is going to come in the Sunday paper. You must be 100% sure on this topic, doctor. So all CD markers. 1 question based on CD markers. 1 question based on monoclonal immunoglobulins in the management and medicine. They are the 2 favorite questions from times immemorial. And 1 antiretroviral drug. Compulsory there, and 1 anti-epileptic drug. You can count. These 4 will come in tomorrow's exam. So question number 76. Very good. Hairy cell leukemia, correctly answered by Raj. So we have pan B cell antigens CD19, CD20, 22 and CD79B, but not CD21. In the case of hairy cells is what you need to remember. So doctor, with this we will take a break. So I just came today to bid you all a good farewell. You all have worked a lot. There were occasions where you were little uncertain, will the state PG will be there or not, etc., etc. Finally it is there. Another 3 days is a wonderful time. Relax yourself, feel confident yourself. Don't regret that you have not done that big, this big and all those things. So you have inspired me to spend a lot of evenings discussing questions, topics with you, and we continue the same spirit with our next group of students from tomorrow. And on Monday, do join us for having a review discussion at morning 10 a.m. on the Sunday's APPG paper. So good luck to all of you.